So the on-label patient selection is patients with, there's a couple of criteria, but the kind of line of therapy criteria is metastatic on standard scans, actually. So CT, MRI bone scan, metastatic, castration-resistant prostate cancer that has received at least one AR pathway inhibitor, so Avi, Enza, Daro, apalutamide, et cetera, and at least one taxane chemotherapy. There's no specific restrictions, and this was based on the study design of the VISION trial of when that could happen. So it was for advanced disease, but that could happen in a non-castrate, aka hormone or castration-sensitive situation, or for castration-resistant disease, including the quote non-metastatic disease setting. So just have to have prior exposure and resistance to those agents, or at least the exposure part about that. So that's the official, FDA label for part of it. The other part is quote PSMA positive. So as I mentioned, that's the vast majority. So it's not typically doing a blood test and looking, trying to find, let's say, circulating tumor cells or something like that in the blood and testing it, or doing a biopsy and testing. It is using an image, a PSMA PET, like we mentioned before. And then depending on how that's interpreted, it's typically 8 or 9 out of 10. So if you look at the VISION study, there were 2 parts to being PSMA positive. So one was having at least one tumor lesion light up greater than the liver. So we look at PET scans are quantitative. We can look at SUVs, and the SUV max of at least one lesion had to be greater than the SUV average or mean of the liver. That was one criteria, and that was 19 out of 20. So 95% of late-stage, heavily pretreated patients with metastatic castration-resistant prostate cancer will have at least one tumor light up. And then there was some negative selection. So the requirement was no significant soft tissue lesions that have uptake less than liver. So significant was based on size. So visceral disease greater than centimeter, and lymph node disease, top of head greater than 2.5 centimeters in long dimension. That was a little different than kind of typical, but that was the negative selection. So that combination led to about 87% being PSMA positive. So that's where I come up with the kind of average of 8 or 9 out of 10. I think that today, kind of the average radiologist, outside of a major center, is probably going to look predominantly at the PET part of it, not so much at the CT component, and might miss some PSMA negative lesions. So, in my mind, that's kind of a mixed picture. So, radium is actually a good example. So we can, in the Alcifka study, patients were allowed to have reasonably sized lymph nodes, 3-centimeter lymph nodes. And there's a survival advantage despite not targeting them on purpose. They had bone predominant disease. I'd say it's very similar. So if someone has a lot of PSMA positive disease and has, let's say, a PSMA low 4-centimeter lymph node, even though they would not be allowed to be in the VISION study, they might benefit from that. And the patients this is not exactly kind of on label, but, patients that have had everything else don't qualify for clinical trial. I have absolutely no problem treating. And even patients that might have PSMA low disease, let's say the liver SUV is 5 and all of their Mets have an SUV max of 4.5. Well, if they have no other options, then at least some is going there, and I would kind of consider that, although that wouldn't be kind of quote on label.